Welcome everyone back to our LifeU class. It's not a matter of if, but when. And this is the fourth class of the series. We'll have one more next month. And today we'll be focusing on the second half of our medical portion. Remember last week we went over a couple of things in terms of going over shock, over bleeding, and over choking. And so today we're going to be focusing on the second half of it. But I just want to let you know that this class is brought to you through Acts of Mercy, which is a disaster arm of the Antioch churches. And Acts of Mercy's vision statement is really just to mobilize the church to engage, train, and prepare in order to offer practical help in times of disaster and to bring sustainable transformation to communities locally and around the world. And so you being in this class here is just really, really important because you're getting prepared to do what is coming. It's not a matter of, like it says, if it's coming, it's when it's coming. So you being part of this is just really crucial. So I'm really stoked that you guys are all in this class here and participating. Just a couple of footnotes. If you have any questions, you can type them in the chat box, and then Kimberly will be monitoring the chat box. And so at the end of the session, we'll have a chance to answer some of these questions. And then just a reminder for the next month's class, which will be the last class. It's kind of a little bit of a free-for-all. It's kind of like a summary class. So we're going to be maybe going over topics that want to be, more clarification, more detail, some things that you might be interested in that you didn't really get enough meat, so to speak, from the first time. So we'll be sending out a survey as to what things you'd like to cover again, or even maybe some topics that we didn't even touch on that you feel really important. And then we'll collaborate and get those all together, and then we'll form what that next class will be, the final class. So, and then with that, Albert Hugo, our beloved Albert, will be our trainer once again for today. Albert is a professional firefighter. He's been firefighting for 26 years plus with Ventura County and now currently with LA County. So Albert really brings a wealth of knowledge in terms of just the basics, in terms of what the simplest things that we can do in times of need and disaster. And he brings it out in a very clear way. So with that, I'm going to give it over to you, Albert.
Thank you, Dennis. Well, good morning, everyone. And it's amazing to see that we still have people that are interested. I know there's things going on, the vaccination sites where some members that would be attending are taking part in some other endeavors. Nevertheless, these classes are going to be available, whether you miss them or you have a friend who is interested, even after the fact. So please share this and make it known to those people that you feel might be interested, because you can always go back to these. Now, like Dennis said, this is the second portion of the medical, and we're just building on everything. So a lot of information. And in the end, our hope is that this will light a fire for you, like I mentioned before in some previous classes, that you are going to decide to maybe look further, maybe taking an EMT class or taking the CERT class, which at this moment hasn't occurred. However, that is coming up. So we're going to cover a variety of different things. And some of these things are also I'm going to tie into what we covered last week and some other things in previous classes. So we're going to be talking first about burns. The skin, for most of you that may or may not know, is really the largest organ in the body, and it has really a variety of different functions that it serves for us. It provides a protective covering. It prevents from excessive water from leaving the body, because our bodies need water to stay alive. It helps protect internal organs from injury, and it also allows us as a sensory, either to hot, cold, pain, or when we're touching something. and it also enables us to regulate our body temperature. So when we're talking about burns, there's 4 typical ways that you could sustain a burn. Thermal burn being something that you're touching, like a hot flame, an object that's been heated, liquid, or even a gas. Now, chemical burns could be strong acids or bases. We can also be subjected to an electrical burn by touching some kind of electrical current. And radiation could be like a UV light, X-rays, or some type of radiant energy. However, even though those are the main types of burns, we're going to cover a couple others. But before we start, I just want everybody to understand that this is an emergency medical preparedness class. So there's going to be some graphic pictures that will demonstrate some of the things we're talking about. But I just want to make it known. So if you see something you feel uncomfortable about, it's not to get that effect out of you. It's just to make a point of what some of the things that you might be dealing with if you encounter a situation like we're speaking of. So we talked about burns, but there's also 2 other ways you could sustain a burn. Friction, rubbing some kind of a surface over the skin can cause a burn, and even frostbite. As you can see, these pictures demonstrate some of these types of things. The knees, somebody who fell and on some kind of a coarse surface and sustained some burns. And those 2 top pictures demonstrate frostbite, which typically affects the extremities like the fingers, ears, nose, or toes. Now, when we're talking about burns, we need to understand the different things that make up skin. So the outer layer of the skin is called the epidermis, and that's the outer layer of your skin, the surface. The middle layer is called the dermis, and the under layer is called the subcutaneous hypodermis, which is made of subcutaneous materials. Now, we're going to talk about different degrees of burns. So a superficial burn would be what's considered a 1st degree. It's on the top layer. Superficial partial, now it's considered a 2nd degree burn, which encompasses the top layer and the 2nd layer of the skin. A deep partial, which would encompass both and start going into the 3rd layer. And what's considered a full burn, or sometimes termed the 4th degree burn, it covers all. It's gone down below all 3 layers and some material like the bone and even the muscle. So when we're talking about a 1st degree burn, like I mentioned, it's a superficial burn. A way to view that would be like a sunburn. It's going to affect the top layer. It's going to be painful, dry. You could possibly see some swelling, but it typically will heal in 3 to 6 days. Now, 2nd degree burn is partial thickness burn, which affects the outer layer, but it's also going into the 2nd layer, the dermis. These are painful to the event that even just some air movement that's going over there, it could be really sensitive to that, or even air temperature. It can look white, very deep red or dark brown, and it could have a reddened, blistered type of swelling, and it usually will encompass blisters. Now, what's called a 3rd degree burn, that's going into below the 1st and 2nd layer. It's deep partial. It will destroy the first 2 layers of the skin. It can appear black, brown, white, or yellow, and it can be relatively painless in the portions that those 2 upper layers and into the 3rd layer have been destroyed, because the nerve endings have been killed or they've been destroyed. However, like with any kind of burn, 2nd and 3rd and 4th degree burns, in the outer portions of that burn, it can be painful because it might just be a 3rd degree burn, as you can see in this hand, but in the outskirts of it, there's still some nerve endings that haven't been destroyed. So those are the ones that are going to be painful. This is almost going to always encompass blisters, and it can result in very severe scarring. Now, the worst kind of burn, obviously the 4th degree burn, it has destroyed the complete 3 layers of the skin, and it now is involving bone and even muscle. There's really no feeling in that particular area because all the nerve endings are destroyed. But again, around the peripheral area of that burn, you can have second or maybe third degree burns that will have some pain to it, but this is the most severe type of burn. So what do we do? So remember, like in the previous class, for those of you that were there, we're going to remember our basics. We talked about airway, making sure we have a patent airway. There's no kind of obstruction, that we are getting breathing in, and that we're having circulation throughout our body. So just remember the basics. Those are something that we are always going to remember wherever encountering some kind of an injury for any individual. So when we're treating any kind of a burn, we want to remember that we are there to make the situation better. We don't want to become another victim, because now we're becoming another problem for those that are going to follow us. So we're there to make the situation better. We're going to put out the flames if we can safely and remove the patient from whatever it is that is burning them. If there's any kind of smoldering clothing on that patient, you can remove it. However, if that patient or that person that sustained the burn has clothing that is sticking to the skin, we do not remove that. You're going to leave that in place. If you can cut around that other area of that portion, we can remove that. But anything that has any clothing adhering to the skin, we're going to leave it in place. We're going to try to cool that with cool water, not cold water, for at least 5 minutes. And when we're trying to cool it, for example, if I have a burn here in my wrist and I'm going to put cool water over it, I don't want to put it directly over that actual area. So what I want to do is place the water above that in the area where you didn't sustain that injury and let that water flow. Because remember, some of that area where that burn has sustained is going to be painful, and we don't want to put undue pain and pressure to that individual that we're trying to help. And if you do have something that you can't remove, you can also soak the clothing that's still stuck to the skin. Again, whenever we are helping somebody that sustained a burn injury, we want to try to cover it loosely with dry, sterile dressing. If there's any fingers or toes, we're gonna loosely cover them up. But also, one thing to remember that a lot of people don't think about, any kind of an injury like that, they can be followed by swelling. So we're going to try to remove any tight clothing, belts, jewelry, a watch, because those extremities can and will start to swell. And then again, we're going to try to elevate that extremity higher than the heart. After you've dealt with that, and somebody, for example, has a first-degree burn, there's some other things that they can do. They can consider over-the-counter medication. And again, like I mentioned, a first-degree burn may take 3 to 6 days to heal. You're going to try to protect it from excessive sun, maybe staying in the shade or wearing appropriate clothing. And if you need to be in the sun and you can't get away from that, try to get a sunscreen protection over your screen with at least an SPF of 30 or higher. Okay, so we talked about what we can do when somebody sustains a burn injury. The things that we also got to remember, the things we shall not do. We don't want to put any kind of ice or cold water, because that can cause more pain and more damage. Ice will cause the vessels to constrict, and we don't want that. We want blood to continue to be flowing, because as blood flows freely in those areas that have been damaged, the blood will bring components that will help heal that portion that sustained the damage. We don't want to apply any kind of antiseptic ointments or remedies. Depending on what your grandmother would told you. I know when I was growing up and we had any kind of burn, my grandmother would crack an egg and put an egg over that area that burned. That's something we don't want to do. We don't want to introduce something that can potentially cause an infection. And maybe back then that's what was common, but nowadays we don't want to do those kind of remedies. And again, like I mentioned, we do not want to remove any piece of clothing that's been adhered to the skin. Okay, so we can also maybe encounter some kind of a chemical burn. When it's safe, again, we're always going to remember safety first and foremost when you're trying to help somebody. If it's safe to do so, remove anything, any clothing or jewelry, like I mentioned before. And if you have any kind of chemical or powdery substance on an individual, you could get, for example, a credit card or something like that. You're going to flake it away from yourself and from that individual as much as possible. Always brushing away from your eyes, the victim, and yourself. You want to make sure that you're flushing with lots of cool running water. And as soon as you can, you're going to try to apply some kind of wet compress. And a wet compress could be a towel or a t-shirt that you cut up. You wet it, you wrung it out some, and you could apply it loosely over that area. And when possible, if there's access to dry, sterile, or clean dressing, you can apply that afterwards. And then we're always going to monitor for shock, because anybody sustaining any kind of burn injury could eventually go into shock, and we covered that in the previous class. So we just want to be careful whenever we're encountering or helping somebody that has sustained this kind of burn, especially when there's no obvious signs of a burn. If somebody was burned because of a fire or some kind of an electrical malfunction, that can be pretty obvious. But if you're ever encountering an individual that has any kind of burn and it's not obvious to you what caused it, be careful, because you don't want to become part of you become a victim as well as yourself, as your patient. Okay, there's also the potential for somebody to having any kind of a burn upon inhalation, breathing some superheated air or some kind of a chemical. As you can see in the picture, there will be some obvious signs, like in this case, this individual was probably in a fire or in proximity to a fire. So they inhaled soot, could be potentially superheated air. You're going to see some signs of evidence of that. Soot around the nose and the mouth. They may be demonstrating some upper respiratory distress, singed facial or nose hairs, and burns around the face, lips, and the neck. But the misconception is that when people are in fires, that they die because of the fire, but what really kills them is the inhalation of the superheated smoke and air. And sometimes these byproducts that burn will release toxins when inhaled that could be detrimental to you. But individuals may also not demonstrate symptoms for as much as 24 hours. Okay, now we're going to transition into wound care. Anybody that sustained any kind of wound, we want to make sure that we are controlling the bleeding. Remember, we talked about bleeding in the last class. We want to make sure we're controlling that. We're going to clean the wound and apply dressing and a bandage. So again, we're going to try to clean that wound by irrigating it with a clean room temperature water. Again, something that maybe was used in the past, hydrogen peroxide, that was used to, it can kill some germs and whatnot, but we don't want to apply that, because applying something like hydrogen peroxide can actually cause more damage. And if we're applying dressing and a bandage, we're going to make sure that we're applying it directly to the wound, and we're going to make sure that the bandage is holding that dressing in place. So I'm talking about bandages and dressing, and something that we work with every day, but some people may not know what that is. So over there on the right, you'll see what a dressing is. It's what's going to be applied directly to the wound. And a bandage, they come in different sizes, different materials. But again, you may not have access to these kind of medical materials, and you can and will have to often improvise and maybe tearing a t-shirt or a towel and use those in conjunction because you didn't have access to these type of medical materials. Okay, so there's some rules about applying dressing. We want to make sure that we've addressed active bleeding. And we're going to apply the dressing over the active bleeding location. But we're only going to remove bandaging and dressing if we've controlled the bleeding. And we want to make sure that we're checking it for anywhere from 4 to 6 hours. So what are some possible signs of an infection? You're going to see potentially swelling around the wound site. You're going to see discoloration around that area. You may also see discharge coming from the wounds. And you may also see indications of some kind of red striations around that wound location. Okay, so I know we mentioned this slightly in the last class, but you may also encounter some kind of an amputation. So an amputation may not be a full extremity. It may be an amputation, partial amputation of a finger or a full finger. But we want to keep a couple of things in mind if we encounter this. We want to make sure that we find that amputation part if we can. We're going to wrap it in some kind of clean material, like maybe a plastic bag or a Ziploc bag. And we're going to keep that piece of extremity in a cool place, but we're not placing it directly in an ice. So right here, you see an example of an ice chest. So if you did have some kind of an extremity, placed it in a plastic bag, maybe put ice in that ice chest and put a couple of towels over it. And you'll put that extremity in the plastic bag on those towels, so it's not in direct contact with the ice. We may also encounter an individual that has some kind of impaled object. For example, right here, we're seeing an individual that has what looks like a screwdriver in his upper thigh area in the front. We're going to not remove it. We're going to try to make sure that we immobilize that extremity, and we're going to bandage around it. And of course, we're going to try to control any bleeding that might be coming from away from that area. And we're going to try to stabilize that area and try to help that individual not move. If that individual needs to be moved, they're going to require assistance, because what we're trying to do is minimize the movement of that particular area. Okay, so now we're going to transition into fractures, sprains, strains, and dislocations. So when we're talking about a fracture, like people talk about broken bones, that's considered a fracture. It can be a complete break of the bone. It could be a chip, or a crack in that bone. An open fracture is when that bone has actually broken the surface of the skin, as you can see on that left side of that picture. And it's pretty obvious, but you can have a closed fracture that you won't see any external indication that that bone is broken. However, there can be internal damage to vessels and tissue inside that portion where that bone has broken.
Can I share really quick?
Sure.
So I don't know, you can't see it, but my thumb is completely fractured. I had an accident and I was rollerblading backwards and I fell and I stopped my fall with my thumb. So my whole weight was on this thumb. And when I got up, the thumb was facing the other direction. So it had to be clicked back into place. So on the outside, it looked fine. But then the fact that it was facing the other way made me realize, I think something's wrong. And then I felt the pain, and it was the worst pain ever. So yeah, sometimes you can't see it on the outside.
Yeah, I've never had a broken bone, but I've been on many patients that had. They can be extremely painful. And like what Pia just shared, it was something that initially she didn't realize. And when she realized it, then she felt the pain. And
Yeah.
It's not an easy thing to sustain for sure.
Nope.
Okay, so we talked about open and closed fractures, but we're also going to mention what is deemed as displaced. So you can have a fracture where the bones are still in alignment, but there's a break there. And there's also a fracture where the bones are no longer in alignment and they're slightly displaced, as you can see here. They're both broken. but one is no longer in alignment. And it could also be a break that will have multiple pieces of bone fragments around that area, depending on what the mechanism of injury that caused that break. Okay, so what do we do? Any kind of break, a fracture, or even for that matter, any kind of sprain or strain or dislocation. Again, some of these are going to be obvious that they're broken. An example, an open fracture. We're going to treat all these like they are, and we're going to immobilize that area. What you want to do is immobilize that area above and below the joint area, because you basically want to make it so that they don't move. And you're also keeping it so that they're protecting that portion of the body that may have sustained that injury. Okay, so if we do encounter this, we will never try to put any kind of bones back in place. We're going to splint anything as we see it. We're not going to irrigate anything. We're going to try to cover the wound with sterile dressing and splint that without disturbing the wound as much as possible. Again, like I mentioned, you want to make sure you treat all suspected fractures like they are, even though it's not an obvious indication. It's a suspicion, but it's better to act like they are. And if they turn out that they're not a fracture, you didn't cause any injury. But if you don't take that precaution, they can sustain further injury to that area because you didn't take those precautions initially. Again, so now we're going to talk about sprain. So a sprain is an overstretched, torn, or twisted ligament, which is a tough band of fibrous tissue that connects bones to bones or cartilage. They're usually located around the joint areas. What you're going to see as far as signs and symptoms, because they could be mild or severe. You're going to see pain. You're going to see swelling and bruising. That patient is going to have limited movement around that joint area, and they're not going to have the ability to put any weight on that particular area. And you may also, at the time of an injury, if you were in the area where you saw that, or the patient himself will tell you that they heard a popping sensation as that portion of the body was injured. So a strain, it's similar, but not the same. It's an overstretched, torn, or twisted tendon. And a tendon is a tough cord of fibrous tissue that connects muscles to bones. Commonly strained areas include the legs, knees, feet, and the back. A strain can occur suddenly, and it can develop over time. Again, similar symptoms, pain or tenderness, swelling, bruising. You could have some muscle spasms or cramping in that area. The patient could be experiencing muscle weakness. And again, just like a sprain, they're going to be having limited movement in that area that was affected. So what can we do? So RISE, which some of you are probably familiar with, we want to make sure that we have that individual rest that area. They don't want to, they're probably not going to want to put weight at all or use it, but we want to remember them because there's some people that are a little stubborn. My wife will tell you that happens with me. I know I strained my back not too long ago, and I still needed things to do around the house. And she said, "You just need to rest." She was right, and I did. But sometimes that's hard, especially for guys. We also want to make sure we're applying ice to that area. And we can do this for 15 to 20 minutes every 2 to 3 hours. When possible, we were going to want to put or apply some kind of a compress. If you can buy these at Rite Aid, supermarkets often will carry these, or maybe a compress can be made by bandaging over that general area. And we're going to want to make sure that we elevate that to help reduce the swelling and keep that person in a resting position. If that occurs for those family members that are around, you're going to be having to help them a lot. because they're not going to be able to do their regular daily things that they typically do. So again, we talked about rest. We want to make sure that there's no physical activity. They don't put any weight in that area. We're going to apply ice to that area. Again, we're not going to apply ice directly to it. If you have ice, you place it in a baggie and maybe get a dish towel, put that over that, because you can get frostbite if you're applying ice directly to the skin and leaving it there. Remember, we talked about having burns with ice, so that can occur. You could get a bag of frozen vegetables, or putting ice in a Ziploc bag and getting a dish towel to cover over that when you apply it to that area. We're going to help reduce the swelling by applying a compression, and we're going to make sure that we're elevating that particular area that was sustained an injury. Okay, here's a short video that's going to demonstrate what we were just talking about.
Strains and sprains are painful injuries to muscles, tendons, and ligaments. They are common workplace and sports injuries that are usually caused by three things: overuse, improper technique, and lack of conditioning. Here's how they occur. Sprains are caused when a joint is forced to move into an unnatural position. For example, twisting your ankle causes a sprain to the ligaments around the ankle as the joint is overstretched out of position. Strains can occur when muscles are pulled, twisted, or torn. When someone tries to lift something before warming up the muscle, the sudden pull on a cold muscle can cause a strain. So how do we avoid strains and sprains? Wear protective footwear to reduce stress on your ankle, foot, and leg joints. Make sure your shoes fit your feet properly. Avoid high-heeled shoes. The higher the heel, the more susceptible you are to a sprain. Avoid activities for which you have not trained. Always warm up and stretch before doing work, exercise, or sports. Do a proper warm-up. Stretch and warm up your muscles before lifting. Slowly move the joints around and get them warmed up. Have good flexibility by gently stretching muscles and joints before subjecting them to stress. Stack your joints. Properly align your arm and your legs. Twisting your limbs under load causes strains and sprains. When you feel pain, lay off. Pain is your body's way of telling you that it needs to rest. Remind yourself to always use good posture. Poor posture strains your lower back muscles. Lift according to good lifting rules, like never lift and twist. Decrease the distance you must stretch to lift a heavy object. Get help when it might be too heavy. And finally, know your body's limits and stick to them. Thanks for watching and have a safe day.
I have to stop the share first.
Okay, so as you saw, I really like that video because it talks about what causes strains and sprains, but it also talks about what you hear. A pound of prevention is worth more than a pound of cure, because you're taking protective measures before something like that occurs. So that's really why that video really hit the target, because it's telling you that we can prevent a lot of these things by taking some of these preventative measures, so that we're not sustaining that. So we talked about splinting, and here you're going to see a few pictures. Again, you're going to find that the most common material used in splinting is cardboard. And as you can see here, these are dedicated cardboard splints. They're great, but you can also improvise. You can use a towel, you can use a pillow, you can use some sticks, some wood. So if we need to do any kind of splinting, we won't often have the materials that we wish we had at our disposal. So again, what is splinting? It's really the most common way of immobilizing a particular injury. We want to make sure we're supporting that area that we're either suspecting a fracture, sprain, or strain, and we're helping to protect it, so that if something or someone bumps it, with a splint, that it's going to offer them some kind of protection. Like I mentioned, cardboard is the most often used material, but you can also use, like I said, pillows, blankets, newspapers, magazines. But wherever we're splinting, as you can see these pictures, you have a piece of twig of a tree, and you have other materials there. We're trying to, if at all possible, avoid using any metal, because once that individual gets into the emergency room, they're going to need to be x-rayed. And we can't take an x-ray of individuals with metal splints. So when we're treating any kind of fracture, dislocation, sprain, or strain, we can also use the body itself. For example, if there's a fractured finger, you can use the other uninjured finger as part of your splint. As you can see here, the picture of these two fingers being tied together with some medical tape. That's what we deem as an anatomical splint, is by using the fractured area with another part of the body that has not sustained that injury. If we do something like this, for example, that picture with the girl on the bottom, we want to fill any kind of gaps, just like when we saw the pictures of the cardboard splints. We may place some, some towels or some other cotton type material, because that individual may be in that splint for a while. We want to make them as comfortable as possible. Again, we talked about when we're using a splint that we're going to support above and below that injury. And something that I haven't mentioned before, and we're going to do an assessment. PMS, what does that stand for? We're going to make sure that we can feel a pulse, that there is some kind of motor movement, and that individual has sensation. So before that person, you apply a splint to that person, you're going to take a pulse. We talked about the different locations of pulses before. For example, if it's in your wrist, you're going to take your radial pulse. You're going to ask that individual if they can move their fingers, and you're going to touch one of their fingers and say, hey, which finger am I touching? You want to do that before and after you apply a splint, because the reason we're applying a splint is, besides protecting it and immobilizing it, we want to make sure and document if they had a good PMS before and also after. And again, excuse me, when we apply a splint, we're gonna splint in the position that we found that injury. We're not going to try to realign any bones or joints. As I mentioned before, we're going to try to fill any gaps. For example, if you sustain some kind of a lower leg injury and you're splinting above and below the knee area, as when you lie in bed, you're going to see a gap on the back of your knee. We're going to place some kind of soft cushioning there, because that individual will be in that splint for potentially a long time. We want to make them comfortable. And we're going to assess, like I said, before and after we splint. I mentioned PMS, which is pulse, motor, and sensation. Sometimes you'll hear that referred to as CMS, circulation, motor, and sensation. Again, it's basically the same thing. It's just doing it in a different way. It's a different mnemonic, but you want to make sure that you're assessing it before and after. And then if you can recall, the last class we talked about capillary refill. When you're assessing somebody's circulation, you could either take their pulse, like that picture there, taking the radial pulse there, or you can press the nail bed, keep it down for about 10 seconds and release it. And remember how we talked about that when you have good circulation, you will typically see the return of that color in 2 seconds or less. So here's a short video that's going to talk about CMS. Again, PMS and CMS, basically, we're just assessing before and after we're splinting.
Hold on. Yeah, I know I'm not sharing. I will fix that. Say something else so that we can get this technical stuff out of the way.
Yeah, most of you are doing these Zoom classes probably multiple times a day or maybe even a week. So there's always little, challenges that we are slowly having to get used to. Again, the reason I personally like acronyms, because there's so many things out there, but don't get too caught up in PMS or CMS. Just remember the concept of why we're doing it. And this video is going to demonstrate that to you.
Let's talk about circulation motor sensation, or CMS. Has to be done before and after a splint is put on our patient. A splint could be simply splinting her forearm, putting on a sling and swath, or even putting a patient in a KED or on a backboard. Has to be done. If you're doing a backboard or KED, we have to do all 4 extremities. If you're just splinting one extremity, you'll only need to focus on the circulation motor and sensation for that extremity before and after the splint. To do that for upper arm, I would check her pulse at her radial artery, making sure that it is present. Ma'am, can you wiggle your fingers? That's checking our motor sensation, and then saying, ma'am, which finger am I touching? Pinky. Which just means that she can feel me touching her until her sensation is intact. If I was to do her leg, lower leg, maybe even the upper leg, I need to check a pulse on the top of her foot, which would be a dorsalis pedis pulse. I can ask her to push down and pull up with my hands to assess motor function, and ask her to tell me which toe I'm touching.
You were on mute.
Oh, sorry.
Now you're good. Now you're
Okay, so again, that video was short, but it's sweet. Like that, she was demonstrating, she talked about backboard and a KED. A KED is a special device that a lot of medical providers, EMS providers, paramedics, EMTs will have. And it's to immobilize the upper portion of a person who may have sustained a neck, back, or head injury. But again, what we're trying to do is gauge that person if whatever the suspected injury, whether it's a fracture, sprain, or strain, has compromised either their circulation and maybe has some internal nerve damage. And we're gauging it by checking their circulation, their motor. Can they move those extremities, and can they feel? We want to do that before and after. We talked about using like what they call a blanch test. And basically it's just compressing the nail bed, or if individuals have their nails colored, you can use the side of the finger, compress it for, 10 seconds or so, release it, and you'll see that color return. We're just making sure that we're seeing circulation, especially in the extremities. And we can also compare it to, say, for example, an individual had a right hand injury, and you're seeing some kind of a compromise. If you're not sure, maybe this individual has some kind of medical condition that their circulation is not like what normal people would have. You can check the non-injured site and see if that nail bed color is returning. If there's any difference between the left and the right hand, that's giving you an indication there might be some more internal damage there. Again, short video, no audio to this, so I'm just going to continue talking. And this is just the blanch test. Again, I talked about the nail beds. We can use some other part, like the skin. He's holding pressure on there, releasing it, and you could see the color return. We want to see that hopefully in 2 seconds or less, which is giving us an indication that they have good circulation. Again, we talked about assessing their ability to move, that they have control of their extremities, whether it be their fingers, their toes. We can ask them, hey, I always like to go for the bigger digits. So for example, in the hand, I'll go for the big finger, the thumb. Hey, which finger am I touching? And you could ask that individual if they can turn their head to the side, because I'm seeing you touch my thumb, and maybe because of the shock of the injury they sustained, they're just telling you it's their thumb because they're seeing you touch their thumb. You can ask them, can you do a favor? Can you turn to the left? And when you're doing that, you don't want them seeing you do that. And then for the feet, I always go for the big toe, either the big toe or the little toe, or the thumb or the pinky, because those are pretty obvious. And you want to make sure that they can actually feel which digit you're touching. One thing we didn't cover, and you can encounter maybe a kind of abdominal type of injury. So an abdominal injury can result in what they're called an evisceration. So if the trauma is serious enough, you're going to see that the contents of the abdominal area, the wall has been breached. So you're going to see some of those contents start to come out. Some of those can be sustained from serious trauma, like for motorcycle riders. If they had a sudden break or they hit something and they're going over their handlebars and they suddenly got their abdominal area hit the handlebars, and or for a bicycle, especially with kids. And you can see that as a result. Again, this can also be caused by somebody with a sharp object that, pierced that abdominal area deep enough that the contents will start to show through the skin. So if we do encounter that, just like in anything else, when we encounter any kind of patient that has any kind of injury, whether it's a burn injury or a kind of a fracture, we want to reassess them. We want to get them, if we can, away from thinking of what their injury is. So especially with little kids, when we encounter little kids that are patients, what we typically do, and we don't even think about it, we get on our knees. We're trying to go to their level. So, hey, I'm going to introduce myself. Hey, I'm firefighter Al. What can I do? I'm here to help you. What's your name? Little simple things that we can incorporate by just trying to make some kind of a contact makes a heck of a difference. When you do encounter an individual that has had any abdominal injury, whether it's an evisceration or some serious pain in that area, what really helps is putting them in a position of comfort. And usually with somebody that's sustaining that type of injury, you're going to see that their neck, their knees are going to be flexed and their head slightly raised, is what sometimes is called as the fetal position. That releases pressure in that area. Just a simple thing, as you can see this individual, flexing his knees up, that takes pressure away from that area. And we're not going to push like with a bone, with an open fracture, anything that's broken the skin. We're not going to put any pressure putting it back. We're going to put some kind of a dressing. It could be plastic wrap, something that's non-stick. And then we're going to apply a wet dressing on top of that because we want to make sure that we're keeping it cool but protected. And again, like any kind of injury, any individual that sustained an injury can go into shock. And as we mentioned in the previous class, that shock is one of our killers. Remember, airway, shock, and breathing and bleeding. So we're always going to monitor, how do they look? You can talk to them, reassure them. Again, any kind of injury that we were speaking about in this class, in the previous ones, we're going to get 911 rolling right away. Even if it turns out to not be as serious as you suspected, it's always better to err in the side of safety than not to. Because even us, when we're out in the field and we have a lot of medical equipment to us, we don't have access to an X-ray. We don't know for sure that an individual will have sustained a fracture. We suspect it, and we're going to take precautionary measures to treat that individual. And then when that individual is sent and transported to the emergency room in a controlled medical setting, when we're treating patients, it's out in the open, it's uncontrolled. The elements are what they are. The heat, the rain, the wind, we have no control over, but we're going to make that individual as protected as possible and make sure that they get the best care that we can render to them. And again, if you do encounter an individual like that, just little simple things that we're just covering in this class will make a world of difference. So I know we've covered a lot of material, and there's a lot of things that maybe some of you maybe heard for the first time, or maybe some of you, because you have some kind of medical background or training, maybe you know that too, and it's maybe a little bit of a refresher. But the simple things that we've covered today in the previous classes will make a world of difference if you encounter any kind of an individual that has sustained some of these types of injuries. So I hope that this class was, and this particular class was really helpful for you. Again, there's a lot of material. There's a lot of slides. I didn't read everything that was written on all the slides, but I wanted to make sure that I covered key points. So at your leisure, when you have time, look at them again, share them. And if you have any questions now, feel free to ask. Or if you have some in the future, you can always, send them by email to either us or Kimberly or somebody from Epicenter. And we want to make sure that we address any kind of questions or if something wasn't completely clear.
All right, that's it, guys. Kimberly, did you want to say something?
I was sent one question.
Mhm.
The question is, why is it important to not remove burned clothing that is stuck to the skin?
Yeah. So, I mean, a lot of us wear clothing that is synthetic. So before, when 20, 50 years ago, probably, when most of the clothes was made from cotton or wool, natural fibers, when they burned, they burned. But now we have synthetic material that actually, when it burns, it kind of melts and it will melt onto the skin. So what we want to refrain from is removing anything like that. If it looks like it's stuck to the skin, you're not even sure, leave it in place. Because if you pull it out, you're causing more damage. And the removal of that has to be done in a burn center, an emergency room. And again, we're there to make the situation better. We don't want to make the situation worse. So we want to make sure that if we encounter that, if you can cut around it safely, say, for example, this was burned over, but the bulk of the back of the sleeve is in place. I can cut this around here and remove the big stuff and cut out the other stuff. So you're just leaving maybe something in place that's small. And again, when we talked about irrigating and cooling, this is the burn location, for example, right here. I'm going to place water above so it trickles down, and that's how I'm going to cool it. If I do place it directly over that wound area, it could be very painful, and we're applying pressure. The water is going to fall. They're going to feel that pressure. You can still get that area cooled. Place the water here, let it trickle down.
So the next question is, if you're on like a hiking trail and you have to immobilize a leg fracture, what is the best way to get the individual back to the trailhead? Or should you just leave the person at the injury site?
It's all going to depend on a bunch of different factors, depending how remote the area you're at. If you're in Griffith Park, they have some remote areas, but it's going to be less of a concern than you're in the Angeles Forest and you're deep into the woods. So you're going to have to make that determination before. But again, I always say that if you're going to make some kind of a day hike like that, do your research. It's find out if you have cell phone reception. Tell family members and friends where you're going. Go in designated trail areas. Again, I'm not going to tell anybody what to do, but if you see, oh, that looks really beautiful, but it's not a trail, let's go over there.
Mm-hmm.
Think twice about it. And if you do that, leave some kind of a mark. If you have flagging, a lot of people don't think about it, but when you're going to go hiking and doing trails, you can go to the 99-cent store and get some flagging. And as you're going, start marking it, because, you're in there a couple hours, you got all cut up with the beauty of the wilderness. And now you're trying to determine where you're at, making some marks as you were going in there, especially areas you're not familiar with. It can save you a lot of heartache. Again, if somebody got injured and it's going to be a ways for you to go, also remember, take water with you and proper clothing in the event that you're going to be there a little longer and it starts to get cold. So you're going to have to determine that for yourself. Can you carry that individual or assist them up without injuring yourself? So if it means you're going to get injured trying to get them up, then maybe the best course of action is get them situated, get them in a place, mark it, look at the time, and go seek help. But if you can help get them out of there without injuring yourself or making that injury worse for them, then you're going to have to determine that on that area where you're at.
Mm-hmm. Yeah, just so you know, when I got my fracture because of my accident, the pain was so bad, I fainted. So I couldn't even walk out of there. The next moment when I woke up, I was already in the emergency room. So that might happen. They might just faint and you have no choice but lift them up.
Well, no, you can just stay there. I mean, hopefully they didn't sustain an injury falling down from fainting, and that's a different, story. But if it looks like they're going to faint or it looks like they're going into shock, sit them down, reassure them, and don't leave them. You're going to have to stay there for a while till you assess the situation. And then, hopefully it's not a full-blown shock that they're going into again. But, before you even embark on a hike like that, hey, where am I going? Is there maps? Notify people. Is there a ranger there? Tell them where you're going. Think twice. And then your health, how, nobody's better than yourself gauging on your health.
Mm-hmm.
Should I really embark on a 10-mile hike where I have trouble going up 2 flights of stairs? Maybe, gauge yourself and take your time as you start these adventures.
Yeah, I was fasting. I was fasting that day. And when the doctor said, when was the last time you ate? I'm like, I'm actually fasting. Yesterday was the last time. And he just shook his head like,
Yeah.
lady, what were you thinking rollerblading, in that state? So yes, I was not yet married to this man. So now I know. All right.
That's all the questions.
Awesome.
Awesome.
Again, if you guys have questions that come up later, feel free to reach out to us. And as was mentioned before, that questionnaire, we really want to gauge the stuff that we covered, the stuff that maybe you want to get more information of, or maybe I didn't make it clear to you. And maybe some stuff that we didn't cover, if it's possible, maybe in the next and last class, it could be material that we can possibly incorporate into that last class.
All right, Kimberly, wrap us up.
Yeah, thank you all for coming, and we should be getting out the questionnaire within the next few days. So if you guys could all fill that out. And I believe our next class is on May 22nd. So we hope to see you guys all there.
All right. Thanks, guys.
Thank you, guys. God bless.
God bless you.
Thank you.
Bye, Miguel.
Bye.
Thanks,
Bye,
everyone.
Lisa.
See y'all later.
Okay. Good job, team.